Next presenter will be Dr. Baharu. Dr. Baharu, everybody know him. He's a senior consultant. Is one of the pioneers, has contributed for the development of orthopedic surgery in Ethiopia. So he will give us his design on treating fracture, some new implant design.
Thank you very much. I think this innovation, this innovation is not for pediatrics. It is for every bone fracture. For that, I designed. This was my dream for the last almost 30 years. Now it becomes real, and I got a temporary patent for this. I will explain this design. As you see my name, I'm a retired orthopedic surgeon. I've been working for the last 34 years, and now still I'm strong. My objective is I have to tell you the field of innovation, and then what's going on prior to this art, and then I'm going to show you the objective and summary of this device, specifically the device compressing, which is different from the previous one, and then how it works, and I will show illustrations. The field of the innovation is the current application relates to treat small size, long bones, femoral neck with a simple way without using many sophisticated devices. It decreases the operation time in order to improve the surgical method of fracture fixation to facilitate fracture healing and prevention of the new fracture. Previously, what was the area which the scientists they designed? This prior art, it is difficult to fix to them a brittle bone. Self-locking expanding is from inside medullary canal, induce a fracture in some conditions on the process, even on the fresh fracture. No destruction of the fracture as needed, avoiding shortening of the limb. No compression of the fracture as needed, and difficult to remove the implant. And then it is only limited to treat only long bones. These are some of expandable nails that was designed in 2019 by a Chinese guy. And then this is the first expandable nail was introduced. The second one is designed by USA from 1991. And then this they push a fluid. This is in a reduced way, and then they inject the fluid, and then that implant expand pressure to hold the long bones. The other one this is another USA patent expandable orthopedics device, and then I think we use sometimes for humerus fracture, but it's still difficult to hold the affected bone. This is another in 2020 in Germany. They designed, but it is not tested in human beings. My objective and summary of this invention is that type of expandable implant used to fix small size bone, long bone, femoral neck, fix as a prophylaxis of brittle bones such as osteogenesis imperfecta, osteoporotic bones. This is a self-locking inside canal out, distract the fracture as needed, avoiding shortening of the limb, no induced fracture, compress the fracture as needed, and easy to remove. We can use almost to all bone fractures, from the small, which is scaphoid bone. Additionally, it avoid reaming, reduce radiation exposure to both the patient and the surgeon, avoidance of the interlocking screw, is minimally invasive and shorter procedure time. Our expandable nail, it comprises 3 components. The first one is a pulling and pushing device. The second one is expandable device. And the other one is the outer case with 3 purposes. These are the illustration of our nail. This is a cover of the screw ends. This is a pushing and pulling device. This one is expandable device, and this is the outer case. In this case, we are using our anatomical nature of this look like a bone and socket joint, such as a femur, and then we design on that base. Here, if we see expandable fixation device in function, already we screwed on the top of the pulling and pushing, and then these pins are come out from the outer case, and then from the inside canal of the bone until they reach to the cortex. And then this expandable nail goes down and then touches to the bottom of the outer case. And then it changes, the nail is very solid type of nail. That is what it shows by screwing the pushing and pulling device downward, the expandable pins slide each on their groove on outer case until they reach holes made for exteriorization. From outer case to penetrate the inner part of the bone until they cross cortex of the bone. This is especially in long bones. And reach to bottom space made for expandable device, contact with the outer case, and the device become a solid nail. That is what we were telling you. This is the nail ready for use. This is how it has to be in the long run. This is the outer case which helps us. It is, oh, wow. This is in situ fixation, outer case. More our function is doing on the outer case. We see these holes where these pins are exteriorizing. If you see, the whole holes are the same size. And then when we screw, the pins come out. There is no movement on the bone, but the expandable nail goes until it achieves its fixation to the bone. This is how it works. This is the first function of the outer case. The second function is compression of the fracture. In this case, the proximal part, the diameter of the hole is the same as the diameter of the pin, but it is longitudinally, and then the pins, when we compress, they bring the proximal fragment down to compress with the distal one. As you see, the distal holes are fixed. In this case, the distal bone is in a fixed place, but we move the proximal bone to bring compression to the distal ones. The other is the distraction. When we have a shortening of the bone, in this case we use this modality. The distal holes are bigger and then its diameter in longitudinally. According to the shortening, we can, when we screw, the proximal hole is fixed to the bone, but the expandable nail goes down, and then the distal bone is, when we screw, it goes down to bring together. That is how this external device used as a distractor. The last device what we have it, this is like extracting and introducing device. This has about 5 millimeter threaded screw, and then we screw the whole system, and then we can tap it to go down. Previously making a hole. For that, I think this device is already patented, and then we are looking for people to work with us industrially. This is what this implant look like. Thank you very much.
For their excellent presentations and introduction. I just would like to ask Dr. Theodros first about bone cement. You have used this bone cement. What is the purpose of this introducing the bone cement in large defective bone? One, is it permanent or temporary? If temporary, for how long it should be kept there? One. After that, if it is temporary, that should be filled with bone graft. And the other question is with the cement. If, because I never use this, I really say, but I came across with bone graft that developed already infection. If infection, okay. If infection developed, does it should be removed, or how long? What should we do? Okay, this please make it more clear. Okay, is it clear? Not clear. Okay, what is the purpose of the bone graft wanting? Okay, very clear this question. And if that is what I came across is that the bone graft, the cement, for how long should be kept there, and if in between, if infection develops, that does it should be removed, or what should we do? Okay, please make it clear this, okay? Is it clear now? Okay, thank you. The second question, Dr. Subakalu, it's wonderful that you have used this flexible nail in children. I have seen that your entry is both lateral and medial. And in Europe, there were the so-called enter nails, such as the same as flexible nail, which is used for elder people fractures in subtrochanteric region. So I remember what I used is there, only at the medial condyle side, the entry, okay? The one nail, after it is inserted, it is rotated, it cross like as yours, so it's stabilized there. Here, the nail difference, what I see is, it doesn't have any bowing or curved. It's not migration upward, cranial migration doesn't occur because I didn't see either olive or just like a rash pin. I couldn't see on the picture, which is curved, okay? That means the question is concerning about the migration fear. One, the other two, why it is necessary to enter both lateral and medial? Because it was not possible to rotate by entering on the same side, okay, on one side. Okay. The third question to Dr. Bahru. Thank you, Dr. Bahru, to introducing such a new innovation. My question to you is that this expansion nail, it is so roughly to the bone or just a local area that it's expanded, just to as if it is to replace the interlocking screw, or the purpose that should be clear, okay? If it is expandable so roughly totally or throughout the length of the bone, doesn't compromise nutrient arteries there. Because one of the rimming problem is that the theory is that always it destroys the nutrient arteries, the value of this bone ossification. Thank you very much.
Thank you. They are very informative questions. So I'll give the chance to the speakers to answer the questions before accepting more questions.
Thank you very much for your question. That is why we designed this type of nail. This nail is selected. Only very few areas are contacted, not the same as the previous ones, where the whole, especially in medullary and long bones, it will not compress. It's simply, I think, according to the length of the bone, maybe in 3, 4 areas where there is no compression to the endosteum of that bone. For that, I think from our design, that is one of the reasons why we selected this model. I think I answered your question. Yes.
Okay, thank you, Dr. Amar, for the question. The bone cements are usually temporary, but the ones that we put in for these ones, they are usually temporary, and we use them just for antibiotic delivery, gradual antibiotic delivery to control the local infection around there. So they are temporary, and they are going to be removed in 6 weeks. And it's also believed that they induce a membrane when you're using it as a muscular technique. There is an induced membrane that forms around the bone cement. When you incise that membrane, just think of it as a periosteum. So you incise it, you make sure you keep it intact and take out the bone cement carefully, and you fill that gap with a bone graft, then you'll have a better union. That's a muscular technique. So it's a temporary one, and we remove it at 6 weeks mark.
Thank you very much again. Important questions. I think the migration risk is the first one. From our small case series, we hadn't so far, except the one we had cortical penetration in trobes that we found that immediate post-op on control X-ray. So the size of the flexible nailing, the proper measurement of the intramedullary canal diameter, so about 80% of that canal should be filled by the 2 flexible nails. Half each, for example, if we measure about 9 or 10 millimeter, that means about 8 millimeter size, 4 millimeter each flexible nailing will be used. So the larger the size we use, the less likelihood of migration will be there because of the crowd, and the 3-point fixation is another important concept. So this 3-point fixation will be at the entry site, over the fracture site, and over the intertrochanteric area where we will end up. We can be sure over the entry site and fracture site, but without CR, it's very difficult to be sure we do have good purchase over the intertrochanteric area. So it's preventable with size of intramedullary nailing and 3-point fixation, appropriate application. Otherwise, I actually start weight bearing as they tolerated. I don't usually delay weight bearing after I'm making sure that this is a stable fixation. So from weight bearing, from subsequently, if it's a smaller size and technically we are not doing it well, there may be risk of migration. It's a good concern. Though we hadn't one so far. Why lateral and medial? I think for retrograde fashion, the advisable method is to use medial and lateral entry. But if we are going from proximal femur antegradely, then the entry will be from lateral side mostly. And in radioulnar fractures, it will be one nail only. So for ulna 1, for radius 1. But for retrograde from distal femur to the proximal one, the advised technique is to go from both medial and lateral. That gives the 3-point fixation a very good purchase, and it will support both the medial and the lateral column of fracture very well. And there are no as such structures at risk from entry point of view. That's the advisable technique for these particular fractures. Thank you.
Yeah, so I think for sake of time concern, we are going to stop here. Round of applause for our presenters. Thank you.
And the moderators, very interesting topics. So we're gonna go out for a quick tea break. Don't forget, we're already running 25 minutes late from our program, so 10 to 15 minutes, that's what you have. So grab coffee and run back inside. We're gonna have so many more interesting discussions afterwards.
Dr. Sentayo is our colleague and friend. He is a well-educated subspecialist in charge of the referral hospital and other practices. And he traveled all the way to present to this audience from 275 kilometers. We thank you. Sente, you are talking on risk factors for delayed presentation among acute trauma patients in the southern part of Ethiopia. So, Edim Twal, you can start. Proceed.
Okay, thank you, Professor Brook. Thank you, Professor Brook, for Okay, thank you, Professor Brook, for your introduction. I will present on risk factors for delayed presentation among acute trauma patients in southern Ethiopia. It's a multi-center general cohort study. It's part of our thematic study. So we get the support from Hausa University, technical and financial support. This will be the outline of my presentation. We have some introduction, objective, methods and material, result discussion and conclusions. So as you all know, trauma is the leading cause of morbidity and mortality. And in 2010 report, the WHO, it accounts for 10% of deaths, and it is 32% more than the total deaths occurred by malaria, TB and HIV. 90% of this mortality occurs in low and middle income countries, and most of the patients present delayed. This is a definition by Lancet Commission. Patients with open injuries who come more than 2 hours are considered as delayed, and patients who come after 24 hours are considered delayed for closed injuries. And as patients present delayed in low and middle income countries, the treatment outcome is also poor because of their delays, and this significantly causes the morbidity, increases the morbidity and mortality as well as economic burden. 60% of the trauma is contributed by musculoskeletal trauma, and traumatic brain injury accounts for 35%. So together, head injury and musculoskeletal trauma accounts for 95% of trauma cases of burden. So in Ethiopian context, we all know that there is high prevalence of road traffic accidents. Mostly this is associated with most of our risky behaviors, like most of the patients in our region, they don't use helmet, especially motorbike riding is common in southern region, and most of them don't use helmet. Most people don't like to use seat belts, and even motorbikes, you can see a lot of individuals in one motorbike. There is no control in the number of individuals in the motorbike as well as in a car. And there are also conflicts here and there. So these are some of the pictures that you can see, like in one motorbike you can see 5 or 6 individuals. This is being common outside of Hawassa as well as in Hawassa. You can see people like this. And this is recently happening trauma in our areas. So this is actually a paper that the videos that we get from YouTube. This thing is still happening in our country as well.
Emergency.
So people are very adventurous, and we will see the complications. So significant number of, there is no actually a broad studied subject, but from our limited resources or limited studies, we see that patients usually present delayed than what we are expected. And there are 2 studies which we use as a reference, and one is an enormous study and the other is a study done in Malawi. In the enormous study, they use this Lancet Commission for Global Surgery classification, and they say that 71.9% of open fracture patients, they came delayed. That means after 2 hours, and 27.5% of them came delayed. And one study which is done in Malawi shows that 34% of adult patients come with delay. And from a study on open fractures that we did on Black Lion in Hawassa, 87% of open fracture patients, they came delayed. So delayed presentation have also complications. So our objective is to assess the prevalence of delay and the reasons for delayed presentation on patients among trauma patients. So the study area is in Sidama region, in Hawassa city. We selected 3 hospitals. One is the government hospital, Hawassa University Specialized Comprehensive Hospitals, and the others are 2 private hospitals in the city, Ethiopian and Dianet. The reason that we include these 2 hospitals are so that we can include all the patients, those who can afford go to the private hospitals, and those who cannot afford come to the government hospitals. And these 2 hospitals, the Dianet Trauma and the Ethiopian hospitals, they have ICU care. They give their care with specialists and subspecialists, just like our hospital, Hawassa University. So these hospitals match. The only difference probably is the expense on these patients. The study was conducted from January 2021 up to December 31, 2021. It's a 1-year period. And the design is a prospective general cohort. And the study population is patients who sustain major trauma. When we say major trauma, we use the Lancet Commission for Global Surgery definition of for musculoskeletal, traumatic brain injury, neck, chest, craniomaxillofacial, and abdominopelvic injuries. So we calculated the sample size with the STATA calculation, and the sample size is 1,262. And we take all sampling patients consecutively. So any patient with trauma, he can, we take it consecutively if he fulfills the inclusion criteria. So we excluded patients who cannot give consent and who don't have a family to take care for them, like psychiatric patients who brought by policemen, and patients who came to us more than 1 week. We consider that as a chronic case, not an acute trauma. So we excluded those patients. We get our ethical approval from Hawassa University RB board, and data were collected by 2 general practitioners and 2 BSc nurses were used, so that we want the data to be clear. Data entered into Excel and exported to SPSS version 26, and further cleaning was done by the PI of the symptomatic team. So we use a univariate, bivariate, and logistic regression for analysis. And these are our results. So total 1,262 patients data were analyzed, and the average age of the study population is 33.3 years old, and 84.1% of them are male, And road traffic accident accounts for the most common cause of injury, reaching up to 65.7%. And most patients come to these three hospitals with a referral. 75.4% have a referral. So when you see the prevalence of delayed presentation, it reaches up to 65.4%. 65.4%. So this is a modeling on factor for delayed presentation. When you see the residence type, we have urban and rural. So you can see that for rural patients who come from rural areas, the adjusted odds ratio is 1.57 and p-value is 0.06. So they have significant relationship. When you see the injury mechanism, bullet injury accounts for a 10% increased risk of being delayed. And financial coverage, most of our patients, they pay from their pocket. So as you know, the health insurance is not there that much. So they have 1.68 times at risk of delay. And when you see patients who have bleeding or not, patient who have bleeding has 4.78% of being delayed. And when you see the prior health facility visit, most of the patients came with us with a referral. That means they have visited other health institution. They are 4.03% at risk of delayed presentation. And when we see the neurological status, those patients who are not alert, who are comatose, as you know, most of the time if the patient loses consciousness, there is a high chance that the family will bring the patient to hospitals. So they think that they need immediate care. So it's protective, and it's the adjusted odds ratio is 0.61. So they are less likely to be delayed. So when we see the discussion rate of delayed presentation, it is nearly almost the same as the enormous study, which is for open fracture up to 71%. When you compare it with the Malawi, it is much worse. In the Malawi, it is around 61%, and it's more in our case. So from the mechanism of injury, bullet injury accounts for most of the patients who are being delayed, and presence of bleeding, and people living in rural areas, and those patients who went to other primary hospitals before they were referred to us, they are high likely to be delayed. So we need to facilitate, because those patients who don't get definitive management at the first hospital or the first health institution that they visit, usually they will be delayed at that hospital, so that increases the delay. So we need to facilitate in patients in a health institution where definitive care cannot be given, they should refer the patient as early as possible. So the data shows significant burden of delayed presentation, and we need to have an interplay between stakeholders so that we can facilitate early referral and decrease delayed management. So this is my reference. Thank you.
The future to be president, now the vice president will be advantageous because we'll have good tea break, lunch breaks, other logistics as well. If he it's ready, okay? እንትኖች ፕሬዘንቴሽኖቹን አሸጋሽገን ነው ኮምፒውተር አስቸገራቸው. That's why.
So thank you very much. I'm presenting a paper on impact of traditional bone setting on functional outcome and quality of life after musculoskeletal injuries. It's a population-based study in the Sidama region. Ethiopia is part of our BOSAD study, and this is a team comprising of the BOSAD team, which has public health experts, clinicians, and of course BOSAD is a national-based study, but fortunately this was a separate component of the BOSAD study. As you remember, we have presented this BOSAD study on the past 2 consecutive annual conferences. That was part of the pilot study, and the second one was the quantitative study. And since this is a multifaceted problem, we have to address the issue of bone setters in different perspectives. One perspective is the quantitative part, the other perspective is the qualitative, and then there are also patients who are staying in the community while getting treatment from bone setters. So we have to address them too. So I have no disclosure except that this was a project funded by AO Alliance. So this will be the outline of my presentation, and as an introduction, the practice of bone setters, as you know, all know that this is a practice which dates back to ancient time and is very deeply rooted into the community practice, and still the bone setters are still the main providers of care, and they use different kinds of splinters to splint injured limb, and that's why we all face in every of our practice such complications. So we have done on this BOSAD study facility-based and community-based study. The facility one was presented a year before, and the other one is a qualitative part, anthropological. It is also another very important dimension, which is done by an anthropologic expert. Hopefully it will be presented in the near future. And it has a thematic approach, and it is, of course, multi-sectorial, right? We cannot eradicate the practice of bone setting only by the practice of this orthodox medicine. There are a lot of issues related to it. And why do we need community-based study? Because there are assumed patients who are staying in the community treated by bone setters and feeling assumed like they have improved or much better after the traditional bone setting practice. So is it true? That was the whole concept. So there are patients having such severe complications, which definitely will come to the hospital, right? These are patients that we see commonly. But there are also patients having complications like malunion and union and the like, but people assume that this is also acceptable, and they tolerate such complications, they stay in the community. So we have to address such patients. That's why we have to go house to house in the neighborhood. So the rationale behind the study was the one thing that I mentioned, and so the objective was to take a community-based approach to determine the clinical outcome, risk factors, health-related quality of life in the Sidama region. And this was involving both urban and rural area. The study design was population-based cross-sectional study, and the study period was 1 month between December and January in 2023. And the study area was, as I said, Sidama region, including rural and urban area. Why? Because we have seen from our quantitative studies that the magnitude of the problem was significantly high in that area. And we have tried to analyze different parameters like demographic data, injury and type of treatment details, complications. And of course, we wanted to try patient-reported outcome measures. And so we used EQ5D measures. And the methods and material was that we collected the data info with AP, and then we analyzed it with SPSS. And we have tried to see the association between the risk factors and complications with binary logistic regression, and also other related risk factors with health-related quality of life. And we have done different models with linear regression. And so what does the result look like? We have seen 830 patients inside the community, and these were collected actually by nurses, trained nurses. And nearly 70% were male, and 56.4 were urban dwellers. The rest were from rural. The mean age was 31.8, and 40% of the patients were farmers, and more than half of these patients, they do not have community health-related insurance. And the result was, as I mentioned, the age was, on average, the mean age was 31, and important parameter was the educational status of the household head, and there was no formal education in nearly half of the patients, around 44% of the patients, and the wealth status was determined, and 33% of the patients were really poor. And the other description was based on the type of injury and complications, and the nature of injury in 62% of the time was closed injury based on the oral description of the patients. And we have tried to see different complications, and the most commonest complications was joint stiffness in 56.8%. So this is the health-related quality of life. Of course, this is very difficult to use a health-related quality of life measure in a community-based study. It has never been tried. We haven't got any even article to describe, to relate with. So we have tried to use 5 dimensions with mobility, self-care, usual activity, or that means the daily activity, and pain or discomfort, and anxiety, depression, with different levels, with 5 other arms with the levels. And so we have seen that those patients on board, like regarding mobility, like 18% of the time, these patients had severe problem, even if they are assumed to be doing well, but they had severe problem. And regarding self-care, 37%, like around 8% of the time, these patients had severe issue or problem even in carrying out daily activities. So there were a lot of issues described in this model. So with binary logistic restriction, it has shown that being poor, or the head of the household having poor income, and having no formal education, and the fact that the patients are having current treatment with TB treatment have shown to have significant risk of having complications. And with regard to health-related quality of life, we have done linear regressions, and the same parameters, being poor and no formal education and having current treatment with TBs, have significantly shown to be quite associated with poor functional outcome. So in discussion, like 56% of the time, our patients had at least one complication, which was described in the questionnaire, and there was no any paper which was done in a community-based study. There are a lot of papers across the West Africa, East Africa, even Asia, with regard to the traditional bone setting practice. They are all quantitative study, and this was the first attempt to do community-based study. But even if it can be compared with hospital-based or facility-based study, in Debre Marcos, for example, in our country, 48% of the time these patients had complication. In Wolaita Sodo, it has shown to be 22%, but our patients had significant complication, even being kept in the community. And joint stiffness, deformity, and malunion were found to be the most commonest complications. In conclusion, TB treatment, poverty, and lack of education are really risk factors for developing complication, one or more complication, and to have poor health-related quality of life. And so the ministry and the responsible stakeholders should take a role here, because there has to be kind of regulating the scope of practice of these traditional bone setters, even in the community. So these were references, even if they are all facility-based or quantitative-based studies. Thank you very much.
Hit glitch in my presentation, some software problems were there. So today I'm just going to discuss some cases which were quite challenging for us and difficult cases. So there will be some x-rays. If some cases we have done robotics, some cases conventional, some revisions, and some HIP cases. The presentation may extend by a couple of minutes. And so we saw yesterday that we have different alignments and alignment philosophy. I'll not waste much time in this. Like this, biomechanics are different. The CPAC classification, you must read all the residents. I must urge that you please read the CPAC classification, because that is the way forward, how to align the knee in various alignments. There are 9 phenotypes. So right now we are resorting to what is called as functional alignment instead of mechanical alignment. That means we adjust the mechanical axis of the knee within 5 degrees of the native 0 axis or of the mechanical axis. So without wasting time, let's go to the cases. So this was a case, old trauma case. You can see that there is a malunion of the femur here and sclerotic medullary canal. The femur has united in extension and in varus. So this is a very challenging thing, because in this conventional TKR, if you want to do, then you have to correct the deformity first and then do the TKR. Or you want to do a single sitting, then you have to break the bone here. Entering the medullary canal also here for the femoral jig is very difficult. And it's a 3-dimensional deformity. So it's very difficult and challenging to get a perfect mechanical access in this particular case. This is the history of the patient. This is the clinical the picture of the patient. It's a deformed leg. There is a flexion deformity. Now this flexion deformity is because of the flexion malunion of the femur as well as the knee. So it's a combined flexion deformity. It's not only in the knee, but it is in the supracondylar region of the. This is now. So, thank you. So it is in the supracondylar region of the femur. So this is the range of movement on table. So there are multiple issues in doing the TKR in this particular case. That is the extra-articular deformity, compromised range of motion, femoral rotational malalignment, intramedullary referencing is not possible, fracture united in extension, so lateral posterior condyle is more anterior than the medial condyle, posterior condylar axis can't be used. So rotational alignment of femur also is an issue here. And femoral sizing is not possible due to deformity. So all these problems we decided to do a medial parapatellar approach, and then quadriceps snip was done because the exposure of the knee is not going to be easy. There is fibrosis there. So we do a quadriceps snip. You can do a tibial tuberosity osteotomy also, but in this case quadriceps snip was done. This was the intraoperative picture. You can see the malunited fracture. So we use the Navio robotic system where we register the joint with the sensors, like yesterday I have demonstrated that. After doing that, we check the femoral center with take the limb through gentle range of motion, rotate it, and you get this change. So femoral head and the axis is not a problem. We take the white side line, and so rotation of the femur also is easily detectable. Then map the tibia. Femoral mapping was used, a robot to assess the anatomy. Robot could not recognize the distorted anatomy, and it showed some pictures, something like this. So sometimes even robot also comes into problem, because now here the robot is showing the implant to be implanted here, whereas the cuts are here. So you have to ignore the robot, use your brain. The robot doesn't have brain. Any surgery, robotic surgery, surgeon has to use his brain and do the surgery. So like that, we shaped the femur and then implanted it. This digital angel wing was used to confirm the cuts, and following which proper implant positioning was planned, and this was the final picture. It's a perfectly well balanced mediolateral balanced joint. So robot makes the life easy, but on table robot also can get stuck up, and that is where you have to use your judgment. And this is the picture of the implant, and you can see the leg has been completely straightened, and this is how the femoral condyles for preparation were there, and final implantation cementing was done, and this is the final x-ray. So in this we have corrected the extension of the femur by positioning the component of the femur in such a way that we get a neutral sagittal as well as coronal axis. The second case, this is the history of the patient. This is the clinical picture. It's an extreme valgus. Now in valgus cases, there are a lot of challenges. People think that valgus is exactly reflection of varus knee. You have to just do opposite. It is not like that. There are multiple lateral structures. The IT band is there. You have got popliteus muscle, lateral collateral ligament. So it's a complex sort of scenario on the lateral side. So you have to sometimes release it sequentially, either start from the IT band and then go to the popliteus, or do a do a lateral femoral epicondylar sliding osteotomy. That many times you have to do that. Now in this case also we did, since it was a very complex case, we did it robotically. You can see that the lateral structures are very tight. Anything below this line is tightness, anything above this is laxity. So in such severe valgus cases, apart from contractures on the lateral side, the main difficulty is the lax medial collateral ligament, because that is one thing which you cannot tighten. So you have to take utmost care and not release at all the medial collateral ligaments. Then the positioning of the implant was done on the robot. This was the planning screen. So you see here, these are the planning screens where we see there is tightness of the lateral collateral ligament, and this is the medial collateral. Orange is medial collateral ligament, and there is a laxity in flexion as well as extension. So we have adjusted, we have given valgus 1 degree, we decided to keep the components adjusted on robot with 1 degree valgus with each the femoral as well as tibial, and the flexion gap was balanced by rotating the femoral component, and you get an absolute perfect balancing, you can see here, and you tighten the joint. So without releasing any ligament, we can get perfect balancing, and that's the advantage of robotic surgery. Otherwise, with the conventional, this would have been a very difficult case to tackle. And this was the final picture, and ultimately the patient gets this kind of report once we do a robotic surgery. And this was the final X-ray. So you get perfect alignment, correction of the deformity without releasing the soft tissues at all. So that's a great advantage. The next case is, this case was a post-operative mid-shaft fracture, lower third fracture, which was plated. There was this implant in situ, and there is a malunion of the femoral shaft. You can see that this has got malunited in varus. So now we have to correct the axis. The two options in front of surgeon are: one, to remove the plate, correct the deformity, let the bone heal, and then do TCAR. That is one option. Second option is to remove the plate. If you are doing conventionally, remove this hardware, and then, with a very long femoral stem, you can have this fixation of this corrected deformity also. We chose it to do it robotically, so we kept the implant as it is and corrected the axis with a robotic surgery. So we decided to do a cruciate retaining joint here. So this was mapping of the joint. We defined the femoral axis, rotational axis. After that, we get this implant positioning. We burred the surface like we saw in the video yesterday, and ultimately we corrected this, and it's a completely balanced joint. So the final X-ray looks like this, that we did not bother to remove the implant. The implant stays there. The deformity is also like that, but it is intra-articularly corrected varus deformity. So the long axis is completely corrected. Another case now, 70-year female with flexion deformity 20 degrees, and this is the pre-op APA lateral X-rays. Again, with robotically, we have taken axis. You can see here now, both medial and lateral compartments are extremely tight here, and that's why the flexion deformity. Anything below this neutral line is tightness. So here you have to resect some more distal femur. So you can see here, this was the first planning screen. It's unequal. This one is slightly tight on lateral side. Medial orange is very tight. 15 is very tight actually. So there is a huge varus contracture on the medial side. So we adjusted femur with the functional alignment. You can see we have given the femur 3 degrees varus here and tibia in neutral position. So the mechanical axis falls within 5 degrees, and so this is the functional alignment. Again, you don't have to release any soft tissues, and you can see perfect balancing, sub-millimeter balancing. So this is balancing in extension, and this is balancing in flexion. So we could get it, and ultimately from 23 degrees of varus, we have come to 3 degrees of varus. So it's absolutely perfectly balanced sort of a joint. And then if we see the range of movement, all that tightness has been taken care of, and we are getting a very good alignment. And this is the final report of the patient, and this is the X-ray. So the technology definitely helps in complex scenario. Like I told yesterday, the people think that it is only for simpler cases, but in complex cases, it is a very good assistant to the surgeon. Another case, this is a operated case with some surgery was done earlier, and this was a laxity in valgus, partially correctable, and a recurvatum deformity. Another deformity which is extremely tricky to tackle is a recurvatum deformity. This was on table. You can see that its recurvatum is almost 30 degrees of recurvatum. So, it's very challenging to, correct this. And mediolaterally also, it is a lax knee. So in lax knee, you have to actually take care that you have to do very, very minimal bone resection. You have to preserve as much as bone as possible, and you have to, don't release the soft tissues at all. This was the implant planning. and finally you can see the laxity, and now this is the final balancing where you are again getting sub-millimeter balancing. It's a completely balanced joint. But we have given external rotation 6 degrees, flexion of the femoral is 6 degrees. So all this flexibility is in hands of surgeon, and on table you can take these decisions to realign, reposition this implant, do a surgery virtually on the computer first while you are before you are actually performing bone resection. And this is the final graph. You can see it's completely, absolutely fantastically balanced. So this was implant planning, and this is the second leg. So you can you can see sometimes the robot also shows a picture which is weird. You can see here how weird it is looking. But sometimes, because it was a recurvatum deformity, it is showing a very weird picture, because computer doesn't understand these deformities. But that is the time when you have to use your brains and then come out of it. This was a planning, confirmation of the cuts, range of movement intraoperatively, and final balancing of the joint. And this is the post-operative X-ray. So wherever there is a contracture in the soft tissue or laxity, the robotic technology definitely helps us. Now in periarticular deformity, these are the challenges. That is the distorted axis of the limb. Preoperative planning is sometimes a problem. This is a RTA case. So I'll just skip the detailed history here and come to the X-ray directly. So this was a picture, So this was the clinical, the radiological picture. You can see this condyle as malunited, 23 degrees of varus deformity is there, and other side it's a valgus deformity. And you can see here there was a lot of bone loss also. I have some intraoperative pictures also. So we did it robotically. We mapped this joint, confirm the positioning of the implant on the computer, again confirm the joint line restoration, and then burr the bone. And this is the final balancing of this particular knee, and this is the picture. And you can see intraoperative pictures where those screws were there, the condyle was completely, actually bone had completely resorbed. It was absorbed, so there was no bone on the posterior side. So in such cases, you may have to use augments also. So this was a right knee where it was deformed and bone loss was there. These were the cuts with the robotic. You can see the robotic sensors being attached. This is the bone preparation and final X-rays. So any type of deformities we can definitely tackle with it. Another case with the implant in situ, a femoral nail was inside with varus deformity. You need not remove this nail and directly go for the robotic surgery. Follow the routine procedures, take rotational axis, adjust it, see the implant positionings, and after that final position is chosen. The cuts are reconfirmed with a digital angel wing, and after this you fix it with the bone cement. So this is how it was finally done. This is the final balancing, and this is the final X-ray. So the implant stays there, you need not take it out, and a cruciate retaining implantation was done. Another case, always implants in situ is a problem. Even if you are doing a hip or a knee surgery, that is a problem. So this was another case with an anteromedial osteoarthritis with tibial nail inside. We decided to do a partial knee replacement. There was no lateral compartment involvement. So mapping was done for partial knee. The implant positioning was decided. It was matched to the bone, exact native bone. So joint line restoration is done to the perfection. Again, the checking of this implant. So actually we virtually do the surgery on the computer here and then burr the bone. Hardly 2 to 3 millimeter bone is taken off and about 4 millimeter from the tibial side. And then this is the final balancing and this is the final X-ray. So this case, otherwise we would have required to remove the tibial nail, again do a total knee replacement, would have been very extensive for this patient. Instead it was just this thing, partial replacement, and completely this thing was tackled. This was an interesting case, a rheumatoid arthritis case with fixed flexion deformity. I have a surgical clip. This was done traditional, conventional way. Robot was not used because patient wanted a conventional surgery. It was very osteoporotic bone, and that's why we decided to use implants which are actually revision type of implants. The video is running in breaks, I don't know, it's not smooth. Wow. So in this, actually, we decided to use stems on both sides because the patient had very osteoporotic bones. So I'm very sorry for this jerky sort of video. Anyway, we did a patelloplasty. You can see the completely destructed bone. We take a intramedullary rod here for referencing for the femoral axis. This is a Merrill implant, and we have a revision Merrill system here, which was used for this particular patient. Videos are really not running smoothly. So this is a jig for femoral rotation. They have got 0 degree, 3 degree, 6 degree. You can have it as either anterior or posterior referencing. We did anterior referencing. This is a 4-in-1 cutting block which was put. And then we completed the femoral cuts on the, with this block. All 4 cuts were taken. Anything can be done to improve the quality of video? No. I think it is large, so. Then we started with the tibial preparation. I always take the Akagi line as a rotational reference for tibia. That is a line which you have to draw with either electrocautery from the PCL to medial 1/3 of the tibial tuberosity or patellar tendon. Then you take adequate bone cut. If you are doing conventional surgery, always measure your cuts. If the cuts are less, then you can recut it and have adequate gap, which is enough to accommodate. So here we are taking 2 mm more because the cut was 6 mm. We had to take more bone from the tibial side. So you always measure the cuts and then go for the further. I think this, I'll just skip this video. It's not running. Anyway, we put the stems on both the sides. So final x-rays were like this, that you can see the long stems on the femoral and tibial side to give additional support for the bone. And since we had to take 2 mm more bone from the femoral side, you have less support on the condyle, and you can see here small posterior condyle was remaining. So it's always better to augment it with the fixation with the stems on either side. This is another video, hope this also runs. This is an interesting case with a stiff knee, and on table actually you can see that this lady had no sort of flexion at all, and this is the intraoperative picture where first of all you have to check it with the patella whether it is fixed, fibrosed. So in this particular case it was completely fibrosed. There was no mediolateral movement of the patella, so we have to dissect in extension and completely take out the fibrosis, arthrofibrosis from the joint. You can use either knife or you can use electrocautery and completely clean the joint. When you are cleaning the joint, remember that you have to go very systematically. It has to be all 8 compartments, that is the infrapatellar just below the patella, then below the 3 compartments in the suprapatellar region, the medial gutter, lateral gutter, below the quadriceps tendon, below the patellar tendon, and medial lateral tibial. So all these 6 compartments, posterior compartments. So all these 8 compartments you have to completely clear, and then after clearing all this, you can get some movement. Now in this particular case, it was a bony sort of a fusion, more or less bony fusion. So you can't bend the knee in spite of clearing all these things. So what we did is that that time the robotics technology was not there, and unless you flex it, robot also cannot go further. So here, after clearing the fibrosis, I took the cutting block and we took the cuts in extension and with a alignment rod like this. So you can see here the alignment rod was taken, and I put this and draw lines here, and with just your judgment, eyeballically, you have to cut the bones on the femoral and tibial side. So you take at a time about 10 mm of bone from the tibia and about 9 mm. So like that, you have to cut the distal femur and the proximal tibia in one go. So I am, cutting this now with a saw. So unfortunately, the video otherwise was a very good sort of a video. Okay. Yeah. She is just changing the computer. Just 1 minute for that. But the video run with that. just hitch a cable on. This has to be connected to the projector. It's connected to the screen. No, it's loose. Yeah, this show this light. Yes. Okay, I think that's fine. So again, I'm going back to this, but it's very interesting case. So pardon me to repeating it. So you can see here that patella, as I was mentioning, I'll just go slightly forward, maybe if you permit, but no. Now it's actually quite nice. So we again to repeat now, you can see here the fibrosis and you have to be very gentle in this because sometimes there is a danger of peeling of the patellar tendon. So now you can see all these 8 compartments systematically, very gently you have to take it out. Once you clear this suprapatellar region, then you go to the gutters. And this takes some time and you have to be patient and very gentle. Now this is the lateral gutter which we are clearing. Then the medial parapatellar, medial tibial condylar side, and put this. I use very small sort of retractors. I don't like to use very powerful ones because they tend to damage the ligament. So I use the radius ulnar retractors as my medial and lateral collateral retractors. This is the intra-articular fibrosis and tissue. And once we do this, you will see now I take out all the bone, but it's completely fused sort of a picture and there is no movement at all in this particular joint. So I have taken this cutting block, aligned it with the second toe here and the hip center. My assistant is keeping a finger on the anterior superior iliac spine. And then with electrocautery, I'm marking my cuts here. You can't use any jig here. You can probably use a tibial jig to mark it, but since your joint line also cannot be actually seen, it is very difficult to see that. So your judgment comes in picture. And then with a saw, you cut this bone, parallel bone. I have marked it here. And once this bone is cut, then entire block you have to remove. So once I cut this bone, gently I flex the joint. So you can see that wedge opening. Again, you have to be very gentle in this particular step because otherwise you can fracture it. You can now see that there was complete bony fusion, the intercondylar notch also. So I take it out, all the intercondylar sort of bony fusion areas and clear that also. So now it is very easy. You can see posteriorly there is fibrosis. So that compartment also has to be completely carefully released. You have to be very close to the bone. Don't go far off from bone. Otherwise there are chances of vascular injuries, and complete the tibial cut. So once this complete tibial cut is done, you check that with a drop rod, check that your cut is in perfect alignment. It has to go to the second toe and that is where it is coming. And then now on here, the surgery is simple. Again, check the gaps with the block, check with the alignment rod because the cut which we have taken was completely eyebolic. Here no technology is going to help us in this particular case, whether you have robot or you don't have. Ultimately, this is a case where it is impossible to do with robotics also. And then complete the cuts with the conventional jigs. So this is the sizer. Here we have done a posterior referencing. With the angel wing, we check that there is no notching here. And then complete the cuts here. Once the cuts are completed, then you cement, do a trial, and then cement the joint, the prosthesis inside. This bone also was quite porotic, so you have to be very careful in such particular cases. In India, we get very small bones, our sizes are generally 1, 2, 3, and this also, in such difficult cases, it's very important that we need to be very gentle. Don't use your shoulder force, just with your wrist force, you have to hammer it, and this is a trial implant being done. Another challenge in this is not bony cuts. The challenge here is also the quadriceps contractures. So I have developed a sort of a meshing technique of quadriceps tendon, where I take 11 number blade, just like the skin graft you expand with the slits with 11 number blade. So here you can see that I take this particular thing and do this pie crusting of the quadriceps tendon, and you can see this is going up to 110 degrees on table with good patellar tracking. And this is the X-ray of the patient, and this is about 3-4 months post-operative. Patient is getting good movement. So very challenging case, and you have to really, these cases are there which are actually supposed to be planned properly. You have to discuss with your team and what is the approach, and then perform this surgery. So the lady is doing well. Subsequently, I replaced her elbow joints also and one hip joint also. So she has my four or five joints in her body, and she is doing well. Another stiff knee. Now that stiff knee was in extension. This particular knee is in flexion. There is just 30 degrees movement possible. So here we decided to use rods. And this patient also, you can see that the patient had a skin graft. It was an old post-traumatic case. Now I'll go to the revision scenario. Now this is one case which came to me, and this was a bilateral revision case. This was operated somewhere else about 2-3 years back, and the patient had this picture on coming. So we did a bilateral revision, single sitting revision in this particular case, and these are the post-operative x-rays, the left side and the right side. So you have to keep your augments, you have to keep your stems, you have to keep, if required, sleeve. Dr. Afram showed me some x-ray just now. That patient required sleeves. So in revision, you have to plan your inventory very carefully and to take it in a very this thing. Another disastrous case came to me after the case was done some 5 years back somewhere else. Alignment was not there, and this was a picture when the patient came to me. There is complete bone loss on the tibial side. You can see almost tibia is fractured. Femur also, a lot of bone loss is there. So you have to keep your inventory in place. So we removed all these implants, debrided it in single sitting. This was having no active infection. Infection profile was done. And post-operatively, this is the picture where you have used the stacked technique of wedges here. We have used 2 wedges here and 1 wedge on this side, and a huge sort of a poly size also, but ultimately, and a hinge. This is a hinge prosthesis. So again, you have to be very careful, plan your inventory properly, take your medial parapatellar approach. Now here, what is important in single stage revision is that you have to debride it extremely carefully. Every small biofilm or your synovium has to go out. You have to, so you can see entire synovium is being taken off before. That is the first stage of debridement. When the implant is still sitting there, we will take it out from all the 8 regions which I mentioned you. From every region you would go so that your undersurface of vastus medialis is completely actually visible. So this is the first side. Then with the osteotome you release the contractures, clear from the intercondylar notch, and take out synovium from the collateral ligaments also very carefully. Then after the first debridement, you take off the implant. With a saw, you have to loosen the implant. Take care that there is no bone loss at all while you are removing this. Otherwise, if you are not careful, there is a chance of huge bone coming out of the native bone, and there will be again a big problem for this. So very gently, with very small thin osteotomes, you loosen the implant and take it out. So you see no bone loss there. So very nicely taken out implants. Same thing about tibia. With a small saw blade, we take off the tibial base plate. Again, we should be very careful. You can see a very narrow osteotome is being used, and then you take out the tibia in such a way that there is no bone loss at all. Then you have to do, I clear the surface of the bone with a saw, and then you have to remove all the entire cement mantle from the bone. It's very tough sometimes if the earlier surgeon had put a lot of cement inside the bone. And with a ronger, you take out all these pieces of bone. With a curette, take out everything from the inside the bone and broach it from inside. Just like we wash the bottle, something like that. Very vigorously you have to curette it out. Then with saw, we resurface take the cuts on the femoral side. So this acts as a debrider also. My saw acts as a debrider. And once that is there, once implant is out, This is the second step of debridement. You again go around all the 8 compartments and take off all the synovium. Once this is done, we put the intramedullary jig for tibial final cut. So hardly 2 millimeter of tibia is being removed, and once that is done, your bones are absolutely clear. Now this 2 millimeter thin bone, once we remove it, see the clear, now very clean bone surface is visible. So there is no chance of any repeat infection or anything like that. You can see the under surface of vastus, very nice. After that, you measure the gaps. In this case, it was around 30 odd millimeters, 38 millimeters or so that you can plan your implants. And this is the final stage of debridement. Again, once it is done, we give a wash with hydrogen peroxide betadine mixture, wash it thoroughly. Then you have to remember, you change the operation theatre, you change the draping, and then go for the final implantation. So we have changed everything, changed gloves, changed gowns. So it is like performing in 2 operations in some single day. So that is how you have to plan it. And then give again with pulse lavage, thorough lavage is given, and then proceed with your implants. So here we are now preparing the tibia. Now the femoral side, you know, this is the for the stem preparation. Then we use these augments and then take cuts. Now here the flexion gap was less, and so we decided to go one size above. Actual size was C, but we took these to close the flexion gap, and took distal augments so that we can close the extension gap. Then you complete the cuts. And this is a trial prosthesis with the required augments in place. So then we put this trial prosthesis inside and check the stability of the joint, and then decide the final size of the poly. So we have taken a 10 millimeter distal augment and 10 millimeters of 5 millimeters of posterior augment, and then here you can see 5 millimeters of tibial base. And now we are checking the stability. It seems pretty good. So we are now ready for final implantation. We tried with one more poly size, and then saw the stability, which thought is better, and finally we chose this particular poly. It's absolutely stable joint, and the tracking also is good. So that is the time when we again give lavage, and then we are ready to go for the final implantation. So see how clean the joint has become. So like that, you have to be very meticulous in your debridement, and then do some multiple small drill holes so that your cement is good. This is the preparation for the revision implant, where we fix the final augments and wedges to the implant. Take 2 packets of bone cement, put it on the prosthesis as well as on the bone, put some bone cement inside the medullary canal also, and then finally you are ready to implant the femur. With thumb, you have to ensure that it's pressurized nicely, the cement, and so it's a very rigid sort of a fixation. Then on the tibial side, same, we press the cement, put slight cement, some cement in the intramedullary canal, apply cement on the proximal part of the stem, and then put the poly and lock it, and you get a locking screw also for LCCK implant, and this is how the final implant is there. We use the vancomycin beads, absorbable beads, in case of infections. In fractures also, in trauma or any this thing, we get this vancomycin beads which are put inside the joint. So before closure, we put these beads, and this is how revision is done. And this is the final X-ray of that particular patient. I'll show some hip cases. I think this is the avian case. Nowadays, we use this dual mobility to a great extent. Merrill has launched it in India. There are some companies which are having dual mobility. The advantage is that you get full movement. Patient can actually squat down, patient can sit cross-legged. The stability is fantastic. There is a long literature from France which is available as far as the dual mobility is concerned. So I do all my hips with the posterior approach. We split the gluteus and then expose it from the posterior side. So Charnley's retractor is applied very close to the bone. We cut the rotators along with the hip capsule in single layer. I don't separate the 2 layers because for suturing it becomes very sturdy, and you can suture it back very well. So once this completely the exposure is done, hip dislocated, check the length, and then do a neck osteotomy. Once that is done, then we take off the head, and we have to expose for proper. My students ask what are the landmarks for the acetabular placement. The best landmark is the natural anatomy of the, unless it is a case of DDH or something like that. You have to expose the acetabulum 360 degrees and from all sides. You can see that it is completely visible now, very nicely seen from all sides. So it's really a child's play to put a acetabular implant. You have to take off all the osteophytes. That's very important to determine the actual acetabular border or lip, and take off all these osteophytes. So this is very important in hip case. If you don't remove it, then it can lever out the hip and cause dislocations of the hip joints. Then start reaming. In reaming, you have to be gentle. So use sharp reamers, but you should not apply a lot of force. I generally do one size less reaming. If you have to put a cup of 52, then go up to 51 reaming. Clear it. Once the fresh bleeding is there, then you know that time for implant has come. And then after this, the acetabular final implant I do. After trialing, if the fixation is good, now you can see that if you are trying to move it, entire patient moves. So you can use screws, you may not use screws, if it depends on the surgeon choice. If the fixation is really rigid one, then it's not mandatory that you have to use screws. Here it was good fixation, but still we decided to use 2 screws for secondary fixation. Then give lavage, and then dual mobility comes that there is a shell here now. So this shell goes inside the acetabulum. And on the femoral side, it has got 22 or 28 head, and then there is a poly. So there are two interfaces where the hip will have movement, and that's how you can get full range of movement in the hip. Then on the femoral side, we start preparing broaching, and you have to get this is a corail-like stem from Merrill. I have been using their implants since their company started, and I have had good results with those particular products. So after this, then you have a trial reduction, and this is how the dual mobility cup looks like. You have a poly cover and there's a head. Once that is done, you measure again that your leg length is restored. It's very important to do this step. So we have ensured that the leg length is correct, and with just thumb pressure, you should be able to reduce the hip joint. And you check the movements now. Everything is okay, then you are ready to have the final implantation. So this is a corail stem. It's a trapezoid stem with this very good rigid fixation is possible with this. There is hardly any case where in last 32 years of my practice, I did not have a single case of subsidence with this kind of stem. And this is how the dual mobility head is locked. You have a ceramic head and a poly outer layer, an interface layer, and they lock to each other with double click. And this is how the head moves inside the second head. And this is how you get double movement here. So the hip is reduced, and you again check for stability and movements. So this is the post-operative X-ray of the patient, and this is the activities of the patient. So patient with dual mobility can squat down, they can pray. I get a lot of patients from Middle East. They require to kneel down for namaz and their prayers. So this is how they are able to do everything. They are able to sit cross-legged. They are able to kneel down. So that's the advantage of dual mobility cup, and with your proper this thing. This is another case of dual mobility. This lady had done hip replacement with dual mobility. So she also was having demand of full range of movement. You can see that very easily they can squat down, sit down, which was very difficult with the old routine hip replacement implants. Another very challenging case which I have faced is this was a Yemeni patient who had come with an old trauma and completely fused hip, and there is nothing visible, no borders are seen. It was really a tough case. To find out the true acetabulum, we had to take intraoperative x-rays. We did in situ osteotomy of the neck, dislocated it, and since the entire capsule was calcified, we had to excise it, so we used a constrained cup. This is another case. We have time, or should I wrap it up? I have one or two. Yeah. So this is the last video. This is, or should I skip the video? This is a DDH. I cannot take it forward somehow here. Another case with a DDH, bilateral DDH, where we operated this Omani girl and did a hip replacement. Now in these cases, you have to do a subtrochanteric shortening osteotomy so that you regain the length and gain the stability also. You have to ream this and prepare the femoral canal. Broach it. Now here we use what is a special hip called SROM hip, where the fixation is completely in the proximal fragment because we have to do a subtrochanteric osteotomy, lengthening osteotomy. So here we do this osteotomy, cut the bone, then see how much is the shortening to reduce the head, and then reduce the head and do a THR. So anyway, I will go forward. Another case of DDH which was done, you can see again the same procedure is done, and with this we get a SROM hip, and we have regained the length also, and again the acetabulum in the proper this thing. We did a bone grafting on the superior lip. Here is the osteotomy and the bone graft here, and we have restored the length in this particular case. This is another case. This is a Ethiopian lady whom we operated. She was here in fact yesterday. This was an old sort of a Tom Smith arthritis where the hip was like this for 40 years. So we did again a lengthening subtrochanteric osteotomy, brought the femur down. You can see the osteotomy site here. Use a SROM hip and a Gription cup on the this thing on side. And this lady had got a lot of publicity in India also because this was in Times of India. Her case was reported. After 40 years, she gained the length, and here she was with me yesterday. Another similar case with the high riding hip. We did a SROM again. So these all, SROM cases. I have a larger series of SROM cases. This is a case of revision where the acetabulum is completely destroyed. Femoral side is also destroyed. So we have used a cage in this case and did this particular revision THR. Another case with completely destroyed acetabulum, we had to use a cage, and we used a long stem on the femoral side. This one more case, with this case was this was a fourth revision actually. This is a fourth surgery which we are doing with all this metal inside, and there was all screws had broken, as if the hip was blasted completely. Very difficult case. We had to take the acetabulum out, all the hardware out, all the, intraoperatively the synovium looked like this. Complete metallosis was there, so it took some time to debride. And finally we got the hip inside, and this is the post-op x-ray with an absolutely fantastic result. This patient, another difficulty was 130 kgs patient, and this is 5'8" and 130, very obese patient. So there are a lot of challenging cases like this. This is a bilateral revision case, we have done with this thing. This was a bomb blast case from Yemen, their war patient, and you can see the acetabulum is completely destructed. So we had to use a bone graft from the head. We did a jumbo cup here with a Gription jumbo cup, bone grafted it and fixed it with Gription with multiple screws. So this is the final picture of this picture. This is almost now 5 years post-op, doing fantastically well. And this is case where again 3 revisions were done, and the patient reported to me like this. This has completely migrated inside the abdomen. So in this, it was a challenging thing, and one should remember that the iliac vessels are in close proximity of the cup, and you should be careful. So for this, I went anteriorly retroperitoneal. First isolated the iliac vessels, which was absolutely sticking here, and one of the screws was almost penetrating that, and we had to carefully remove the acetabulum from anteriorly. Then we removed the head also, then closed that wound, went posteriorly and did a revision of this particular case. Again, acetabulum was destroyed, so we had to use a cage here. And this is the final x-ray of the patient. So these are some of my cases. Every day we do 20-25 joints or maybe more, and every day face some challenging cases. I am really thankful to all of you for allowing me to share my cases here, and very sorry for my computer glitch. You know, it is beyond my control. Thank you very much, sir.
Presenters, አለቃ ኤፍሬም ያሉት ትንሽ ናቸው. We do fast, kind of long lunch. I'm so tired. So ሰፋ ያለ ምሳ ዘና ብለን እንድናወራ. Let's have the other talks. Finally, we'll wrap up and we'll have extended lunch times for socialization. The next papers will be chaired by እያዩ ወደ እኔ ነው ያደረጉት. ያለም is a PhD, just finished. መጀመሪያ አጨብጭቡለት. He just finished his PhD. እያዩ ነው የምንለው እኛ. He is orthopedic anesthesiologist ነው እኛ የምንለው. This is a new title we gave him. He has office in our building. He is interested in orthopedics, MSK anesthesia. He is our great friend. God is the first anesthesiologist, so he made, patient lied and born. The surgery also is orthopedic, chest no ilalu. It is from iliac crust and ribs, still we use for grafting that area. So without him we can't do anything. But I'm going now. His interest is in trauma. He published a big manuscript plus 2-3 papers on pre-hospital care. ስንታየው ቅድም ታወራላችሁ አብራችሁ. He had a good paper on this. የቅድሙ mess. We know patients when they come to the hospital. What the hell happens between injury and the hospital? Only God knows. So he published on that. Community-based, multi-center. It's an excellent paper. I invite you to read. He published those papers. Under his name, you can log in and say pre-hospital care. 3-4 publications. He is also my good friend. Maybe more than 10 years we have been working together on medical legal boards. He represents anesthesia side. And today, this is important. When you focus on surgeries, you miss this part. And once you are in problem, it's a big problem. Therefore, as a reminder, we included this in the ESOT presentations. He's going to talk what are the claims? What do patients claim on us? We had this talk a few years back, but again and again we have to do always see trends, changes, so that we'll be careful during our practice and will remain protected. With this said, Yaya, you are ready to present. The podium is for you. Cheers.
Thank you very much, Professor. So as he introduced me. I am Yaya from Addis Ababa University, Anesthesia Department. I'm an assistant professor and I'm a final year PhD student. Just I'm waiting the graduation. As he said, I'm interested on trauma care. As you know, in our country, the trauma care system has a lot of mess-ups. So my interest is just as a team, we have to improve the trauma care system in this country. But today I'm coming with another topic, which is more focused on the medico-legal issues. I'm going to report the medico-legal issues which are investigated at Addis Ababa City Administration FED or FAMACA from 2015-2023. By this occasion, I need to thank you, the society, to give me this chance. And at the same time, I'm happy if you give me an opportunity to thank my advisor, Professor Brook. He is my advisor when I was doing my PhD. Thank you, Prof, again. So, as I told you, this is just a real scenario or a real report that we faced in the medical legal committee. These were the co-investigators working as a committee member, and also they had contribution on this research from your society. Dr. Misgana was involved. These are my outlines.
So let me say something about the background regarding on the medical legal issue. As you know, health professional care system by itself requires adequate knowledge, skill, and attitude. No health professional wants to harm patients, but even if we are doing to the best of our knowledge, to the best of our skill, some occasions may happen. In that scenario, medical legal issues may be, or lawsuit may be happen. Medical legal issues, it deals with medical law and the right or responsibilities of the health professionals and patients. And health professionals have legal duty to adhere to reasonable standard of care while interacting with patients. They are also involved applying medical knowledge for legal purpose. When we see the overall pattern of medical legal issues in the globe, we have tried to see different literatures from different corners of the world. For example, as you see from here, a study done in Saudi Arabia, medical legal issues are more occur in the operation room and emergency departments, and surgery was the most error-prone specialty for medical legal cases or lawsuits. Another study from India, most medical legal issues are related with road traffic accidents, and men are more affected than the other age group. Another study from Egypt shows that the medical legal issues are more claimed in relation with surgery and obstetrics. In Pakistan, again, it is similar with that of the India, which is more associated with road traffic accidents. In our setup, as you all know, Professor Brook and his team had conducted the research from the Federal Ministry of Health Professional Ethics Committee. In that study, 125 cases were investigated within 7 years. From that study, we understand that 57.6% of medical legal issues were associated with days, and 94% are coming from hospitals and related with surgery and in some obstetric cases. We have also tried to see what are the driving forces that push the claimants to claim for medical legal issues. There are a lot of literatures regarding on this issue, but the most common factors are associated with financial motivation. Most commonly, they need reimbursement or financial support after some incident happened in the hospitals. After saying this, let me tell you some information about the committee that established at Addis Ababa City Government, FMACA office. This was established in 2012. By this time again, I want to acknowledge Professor Brook because he was the founder of this committee in this establishment period. And he was the president and the vice president, the chairperson for that committee. And the committee was established by Proclamation number 30, 2012, and it has its own guidelines and SOPs, which it follows when cases are investigated. These are the committee member composition, which includes different professional societies. Your society is represented there. And to know you, because when I had some discussion with my colleagues, they don't have adequate understanding about the composition of the committee. If you see at the last, this area, there are 2 representatives from the House representatives of Addis Ababa city and 2 legal officers from the FDA and from the Addis Ababa Government Justice Bureau. So far, this committee has handled 282 cases. From this, 210 had been investigated or included in this study. Our interest, why we need to prepare as a research is, even if 282 cases have been opened as a medico-legal case, the pattern of this medico-legal issue is not well studied, and we need to show for our health professionals and for our stakeholders. This is the general objective. It is to assess the pattern of claimed medical legal issues and challenges encountered in handling cases at Addis Ababa. The study is a mixed method study. Due to the time constraint, here today I'm going to present only the quantitative one, because there is no adequate time, as I have informed from the organizers. But the study design was explanatory sequential mixed method research, and the data was collected from 2015 to 2023. And we have got IRB approval from Addis Ababa University and support letter from FMACA. Now let me come to the result. First, we have tried to investigate the biographic data. Almost 92.9% of claimants are coming from Addis Ababa, and around 3.3 were from other regions. When we see the age, the majority of cases which the committee investigated was between 18 and 45 years of age. Then gender distribution, female cases were more dominant than male. When we see the ownership of the health facilities from which the medical legal issues has raised, private institutions were dominant, it accounted 55%, and government hospitals were 40%. Who brought the case to the committee? Claimants around 34.8%, relative and families are 33.8%. Sometimes cases are brought by police, and it was accounted 22.4%, court around 2.4%, like that. Patient condition at admission, management at emergency department. Most cases which have been investigated at the committee was patients which are admitted or seen at emergency department. Most of them. As you see from here, life-threatening emergency cases like labor, trauma, and other medical or other emergency conditions were 58.6%. And the other were emergency or cold cases, but not emergency or cold cases, around 37.6%. From this, especially for life-threatening emergency condition patients, for 27 of them, they received CPR resuscitation. Around 4, they got ABC management or resuscitation and other supportive cares. We have also investigated whether the duty physicians were in duty or not when the patient came for seeking of medical help. Yes, the primary health professional were available, around 64.3, but only 10% of the expected duty physicians to be consulted or as a second consultant were available. When we see the medical legal landscape by specialty, as you see here, the majority of cases were obstetrics and gynecology, and the second one was, as you see here, the general surgery, and yours discipline is on the third place. Okay? On the third place. Okay. We have also tried to assess the claimant's status and confirmed cause of death when they opened the medical legal case at the committee. Almost 44% of cases were opened because patients were died. And 30% were alive with some complications and some limitations of their life, and the 60% was with minimal limitation. The main reason for this complication was hemorrhage, hypoxia, cardiopulmonary arrest, multiple organ failure, and this were the causes which has been investigated by the committee. The reasons for complications, actually, one of the presenter was presented before about delayed diagnosis and treatment, and the major cause why health patients or their relatives open medical legal case was delayed diagnosis, delayed referral, and delayed treatment. This was the main reason that we found in our investigation. The other one, we have also assessed whether there was limitation in resource or in other scenarios, and we asked for the availability of resources in that facility. Only 41%, rather 19.5% were answered that there was no problem on the availability of resources, but 37.6% says that no, the appropriate resources, especially on the emergency department. The limitation of the resources were lack of emergency medication, lack of oxygen, lack of medical equipment, and in some institutions, lack of service provider, like that of ICU department, NICU, and diagnostic procedures. The other one, why they open the file to this committee? Because the majority of the claimants, they think that medical error has happened. It's around 49%. Some of them, they need reimbursement. It is around 14%. Some of them, they need to teach that case to help for other cases or for other individuals or to teach others. The other challenge we found is the committee found that there was a big communication gap with the patient and with their relatives. And it shows that 71.4% of cases had communication gap. The communication gap was unable to deliver the right information to the right people at the right time. This was the main challenge. That is why claimants open cases. Ethical breach was identified by the committee. It was around 69. From 69, the ethical breach was 23. Negligence, malpractice, and treatment error was 69.7%. This is the disciplinary measure by professional category. OB/GYN is the first, it's around 14.6. Clinical nurses is the second. General surgeon, midwifery, and yours is on the fifth, orthopedic surgeon. Disciplinary measures taken by the committee was oral warning with a letter of warning, revocation of the license, revocation of license for 4 to 6 months was the highest. And as you see, there are different disciplinary measures taken by the committee. At the same time, we have also, time ጨርሻለሁ ተብያለሁ ግን 2 minutes እባክህ ልለምንህ 2 minutes. Ethical committee has recommended a significant action for the health facilities, like that of oral warning or written warning. Even the committee has decided to close the health facilities. The discussion part, let me focus on the most important things. Already it is under the publication process. Within 2 or 3 weeks it will be published. Already it has finalized, so you may get it in in website. So I need to focus on some discussion. The majority of cases are related with OB-GYN. This is aligned with the study done in US and in Egypt also. The potential explanation was complexity of care, communication gap, and systematic error. The implication is here we have to improve the communication and enhance our approach. The other one, the major problem is the communication gap. In our study, 71.4% of medical legal cases were related with communication gap. This was similar in a study done in US and Australia. The potential reasons was because health professionals are working in a complex area and a complex medical information, time constraints, lack of cultural sensitivity, and this tells us to improve our communication skills and emphasizes patient involvement in our care. And this is my conclusion. My conclusion is high-risk patients, a significant portion of medical legal cases involves critically ill patients, suggesting potential issues with early intervention or resource limitation. Communication gap is one of the major challenges, so we have to work on improvement of communication gaps. The other one is disciplinary measures. OB-GYN nurses and surgeons are the most health professionals who faced for such like disciplinary actions, so we have to work with them to improve their approach. And the other one is delay in collaboration. So again, we advised the health professionals as much as possible to start their treatment as early as possible. These are my recommendations, and the references are there. Thank you very much.
Thank you, Dr. Yayala. Now we'll proceed with the next presentation. I will invite Dr. Baharu to the floor.